My name is Hannah Gabrielson, and I'm an emergency medicine resident at Baylor University Medical Center. Today, I'm going to be talking about one of our studies, which is regarding the prognostic value of cardiac troponin in patients who present to the ER and SVT. I have no financial conflict of interest to disclose. So just starting off regarding some background pertaining to SVT, it accounts for roughly 50,000 ER visits a year in the United States. Of those ER visits, there are more females who visit for SVT when compared to males. This aligns pretty well with the overall gender prevalence of SVT, with it being female predominant of about 2-to-1. The overall prevalence of SVT is about 2.5 per 1,000 people. While not overtly common, it does explain why it's something that we see not infrequently in the ER. So there have been quite a few studies in the past to evaluate the utility of troponin in the setting and scenario of SVT. Two of those studies are here on the screen. The first one being a study on the left, with the title being Assessment of the Utility of Ordinary Troponin in Low and Intermediate Risk Patients. That study showed basically no prognostic value or utility in ordering a troponin. Didn't really help decide, is this patient at a higher risk? A lot of studies align with those results, that really there's no utility in ordering a troponin. And from various practice styles, some people don't even order a troponin because of previous studies such as that saying that there really is no utility in it. The study on the right did have a different result to that, and that studies the prognostic value of cardiac troponin levels in patients presenting with supraventricular tachycardias. That did show actually a prognostic utility in troponin, but only in patients with underlying CAD. So outside of that, it wasn't really found to have any prognostic utility. So onto our study. Our study was a multi-center study at 15 different community ERs in North Texas. All patients involved were 18 years of age or older as an inclusion criteria, as well as presenting in SVT. And our study was retrospective in nature. So our primary outcome that we were evaluating was 30-day major adverse cardiac events, or MACE for short. From here on out, it will be referred to as MACE. MACE includes acute MI, coronary revascularization by PCI, CABG, as well as all-cause mortality. So it encompasses a lot. Our data specifically was analyzed using multivariate logistic regression to examine different factors associated with 30-day MACE, as well as elevated cardiac troponin levels. Overall, there were 147 patients who presented in our study for SVT, with a total of 31 of those patients having elevated troponin values. There's a slight female predominance in our study, and while not quite 2-to-1, it still fits with the fact that there is a higher prevalence of SVT in females, as well as more ER visits yearly for females by females for SVT. And then the median age of our cohort was 62. Here you can see a little bit more demographic information regarding our cohort. Median BMI was in the obese range at 31. Roughly 11% of our patients had known CAD, with 9% having known CKD. So our study found that there were various factors that were associated with elevated cardiac troponin. one of those being CKD. And I doubt many listening to this find that surprising, considering we do tend to find chronically elevated troponin levels in patients with moderate to severe CKD in the ER, with this likely being due to decreased clearance of troponin. In addition, though, elevated troponin was in our study associated with a lower mean arterial pressure, as well as a higher ventricular rate. So these two correlations do make sense clinically, as decreased perfusion as MAP decreases could elevate troponin, and then on the other end of that same kind of spectrum would be the potential decreased perfusion as a result, as like related to demand from increased ventricular rate. And while that could be due to underlying CAD, kind of tying that back into the other study that was done, at least having known CAD in our patient population was not found to be a risk factor for elevated troponin in the setting of SVT. And then now on to risk factors for MACE. One of the risk factors we found for major adverse cardiac events after SVT was male gender. And then the other risk factor found indeed was elevated troponin. So while being male did increase your risk for MACE, one could like speculate why that is. We don't really have an answer other than the fact that it was a risk factor for a major cardiac event or a major adverse cardiac event after an SVT event for which someone presented to the ER. The other risk factor for MACE was elevated troponin. And so this does conflict with prior studies because it wasn't elevated troponin in the setting of CAD or elevated troponin in the setting of CKD. It was just isolated elevated troponin when a patient presented for SVT. And this is important just solely for the fact that it can be practice changing for people. While it was one isolated study, it kind of makes you think if this is something that you should be ordering more often or ordering in select people to determine if they are at risk for a major adverse cardiac event, if you can send them home, if they need to be observed, etc. So there were a few limitations to our study, one of which is the retrospective nature as well as its overall generalizability. Our cohort was limited to the North Texas ERs that we studied, and this may not be able to be generalized to populations outside of this area in its kind of demographic proportions. So overall, while our results do differ from prior studies, it does reiterate the question that we tend to ask ourselves on shift with these patients, which is, should I order the troponin? And if you do, what am I going to do with the results? While more studies are needed to further elucidate this and see like what we're going to do with this, from our results, ordering a troponin on patients who have known risk factors for MACE could be beneficial at determining a safe disposition or even a safe follow-up plan for that patient. If you have any questions, feel free to email me at the address listed below. And then thank you for listening and enjoy the rest of your day.